Mr. Chairman, ladies and gentlemen, good morning. It is really honored for me to give a talk different clinical spectrum in the SIP cases. My friend Sanju Karla has presented nicely about the SIP cases, so I will present a couple of cases of the clinical spectrum of the SIP cases in my clinical practice, especially in the acute coronary syndrome. This is one of the patients of 56 years, male, and presented with AMI inferior and delayed arrival. He has an ongoing chest pain and profound hypotension. This is the angiogram. You can see that RC is 100% blocked, and LCX is also blocked, mid segment, and LED. In the proximal segment of the LED, there is an aneurysmal dilatation, and before that, 199% block, and after that, CTO. So this is the scenario, and LCX is also a reasonable sizable vessel and short segment narrowing. So what to do of this case? This is the acute coronary syndrome. Should we send a patient surgery or should we go for the PCI? Definitely we'll go for the PCI. But problem is that what will be the outcome of the LED? Because LED is an aneurysmal dilation proximal segment. Before that there is a narrowing. After that 100% narrowing. And nothing is seen retrogradely. This is a very difficult scenario. So our plan is do the RCA first and microcatheter. This is not a simple lesion. We have to little struggle, use the microcatheter, and we have to use the suction catheter, peridilatation, and we have used the 3 stent subsequently. I will not elaborate this. And post dilatation. And this is the final result. So RCA is a huge RCA. Now you can see that there is retrogradely filled up by LED. Now you can predict that the LED is also reasonable size. Before that, nothing was seen in the LED because RCA was also blocked. So we plan to do it in stage procedure, not in the same procedure. And the LCX first, LCX is very simple. And this is the angiogram again. And in the stage PCI, we have done the RCA first, the stenosis pattern, and LED, dilatation, and LCX. We have done NCX first, and with a good result. Then we have done the LED. And LED really tight lesion, so we have to use the filter XT with a microcatheter. So it is very difficult to cross the lesion, but finally we succeeded. We have done the IVUS. The problem is that what will be the distal reference diameter? Sometimes if we don't use the IVUS, we cannot measure the distal diameter. Also the aneurysmal segment. What will be the diameter of the aneurysmal segment? That's very important because we need to approach the stent properly. So we have done the IVUS. Now we can see that the distal refer 2.9, and this is the IVUS. I will not go in details. And IVUS proximally refers diameter is 4 millimeters. Now other part is very simple. We have put the stent here and one stent distally. And one is the proximalis, just at the ostium. We did not cross over the stent. And this is the final result. So final result acceptable. The patient is on 6-month follow-up. He is asymptomatic, has no symptom. We are planning to do a check angiogram, and patient is convincing for that. Only the academic purpose, nothing else. Because this is the aneurysmal segment, we post-dilated 4 millimeter. So definitely the aneurysm also, in aneurysm properly approached, and in the LED, there is a little oversizing, but this is good. So this is the IVUS finding, and it is acceptable. And now another case, 58 years old, female suffering from hypertension, diabetes, end-stage renal failure. patient is on dialysis for 2 years, and on dialysis for the last 1.5 years, and he complaining of chest pain during dialysis, and there is a profound hypertension during dialysis, and the patient come back to work with unstable angina, and then we have to go for the angiogram. We can see that the angiogram, this is the angiogram picture. The LCX ostium is very tight, and LAD proximal segment is also diseased, and this is the LAD proximal and a long lesion. So this is truly bifurcation lesion. So we have learned a lot about the which strategy is better of this. Remember, patient is on dialysis, and in this case we have done the definitely IVAS must be used in this case because proper sizing and optimization is very important. So, and there is a arch of the calcium here. So, in the calcium, may not be rota is best option. IVL may be the better option, but at that time, IVS was available in my, but I think so it can be cracked. So, we have done vigorous post dilatation, and this is the decay crash. I will not go in details. Now, this is the final result. So, LAD ostium 10, proximal 9, and mid 9, and distality 6. So, result is acceptable and maybe best. And I was finding mid and final IVAS. This is the left main, distal left main 12, mid segment to proximal 12, and MSA 18 millimeters. So this is reasonable, very good size. And but unfortunately, the patient come back again complaining of unexplained chest pain, and chest pain cannot be explained. So patient asking me to go for the angiogram. So I haven't done an angiogram. We can see that the left main is tennis pattern, proximal is tennis pattern, and but there is a two aneurysmal dilation in the proximal part of the stent of the LAD and in the proximal part of the LCX stent. So my question is that what are you going to do in this case? And in my imagination, I was thinking that I will put the patient on maximum medical therapy and assure the patient, but unfortunately, patient complaining of severe chest pain during the dialysis. And we have done an angiogram. We can see that LCX is 100% blocked. And there is a troponin with troponin elevation, but this is the condition of the patient. Now, I am putting this question to you. What are you going to do of this case? LAD aneurysmal dilatation, LCX not total, and there is one stent, there is a decay crash, two stent in the left main, and one stent in the proximal LCX, and one stent in proximal LAD with aneurysmal dilation. What would we do now? And last case, this is the patient of 54 years, inferior MI, EF 35%, type 2 respiratory failure, patient is mechanical ventilation with septicemia. So patient is on shock and the septicemia. And this is the lung, and after the X-ray, this was more worsening, and we can see that in EKG, there's only inferior MI. So inferior MI, profound hypotension, cannot be managed medical management, and patient mechanical ventilation and oxygen fall more and more. So we have to rush, and we have taken a critical care discussion and all the intensive and respiratory presentations, really, and we have explained to the patient. So we put the patient on medical management for 24 hours. And what investigation shows that hemoglobin 12%, creatinine 2, troponinized 7, troponin elevated significantly, CRP and procalcitonin also significantly elevated. That indicates really this is a septicemia, no doubt about that. So what is the guideline? If the patient comes with the acute coronary syndrome with shock, patient has to be revascularized, either PCI or CABG, no doubt about that. So what is the background? Mixed cardiogenic shock, septic shock is common, associated with high mortality. And there are limited contemporary data on concomitant sepsis in acute coronary syndrome complicated by cardiac shock. There is no definite guideline for that. What should we do? We should defer the case or we should do it on the same setting. That's a different question. And there is no that we have to do like that recommendations. So this is the, you can see that the 100 microgram infarction, systemic inflammation, inflammatory cytokines, and the vasodilatation. And the cycle is recycling again and again. So we have to deal both of that, both the microinfarction or non-STMI as well as the inflammation. We have to cut down both of that. So we have to and this is the LAD. You can see that this is diffusely diseased LAD, and RCA is also tightly diseased. So our plan is to do the RCA first. We tackle the RCA. RCA is not very difficult case. And then on the subsequent stage procedure after 1 month, and the patient, believe me, patients improve nicely after doing the RCA. So if we don't do anything with the coronary, patient may die. And because we have, first we have maximum antibiotic for 24 hours, then we do the CBC when it's come down, and then we take back into the cath lab, and then we have done an LAD. So on conclusion, ladies and gentlemen, AMI with coronary syndrome, concomitant sepsis is associated with higher mortality and morbidity, no doubt about that. Needs for early recognition and integrated management for the mixed shock, emergency revascularization with either PCI or CABG, suitable patient must be considered. So thank you for patient hearing. I think so this group now, as the patient is becoming elderly and so many comorbidities coming up, some of the time we are faced the MI with sepsis. So that's why we have to address this patient integrately by critical care, respiratory physician, and we have to take care of the patient. Otherwise, the mortality is too much high. Thank you for patient hearing.
Hello, microphone test. 1, 2, 3.